I actually don't head the clinic. Georgie Lachlan heads the clinic, and I've really only been looking after PWS patients since I became the director, which was, I don't know, a few years ago now. And I'm learning every day, and I must say I learned a few things preparing this talk that I'm a bit embarrassed that I didn't know about before, but anyway, there you go. So in driving here last night with my husband, who's a forensic psychiatrist, who's, all psychiatrists are a bit crazy, we drove past the Prada shop, and then he started saying, "Devil wears Prada, Prada Willy, where's the devil in the willy?" Anyway, let's start. So hypogonadism in Prader-Willi syndrome is what I've been asked to talk about. And just as some general points, nearly all males and females with Prader-Willi syndrome have hypogonadism. One thing that I didn't know is that, this is my admission of lack of knowledge, is that primary gonadal dysfunction is a major contributor. So we think that it's, that everything's to do with hypothalamic disease, the abnormal appetite, etc., but there's with the hypogonadism, there's certainly issues with the actual function of the ovaries and the testes. Now, despite most patients having hypogonadism, people with Prader-Willi syndrome display a strong interest in sexual and romantic thoughts and activities, and I'm sure anyone who's dealt with adults or teenagers is aware of this. When we're treating patients with Prader-Willi, that's going to be slightly different for children. It's going to be somewhat different for puberty induction versus actual hormone replacement, and obviously treatment's going to be gender specific. And I think one important point is that there's very scant evidence base for all of this, except for testosterone replacement in males. There's really very little data. So we'll talk about, we'll go through men and women through this talk. So as I said, traditionally, it's the hypogonadism in males has been, or in both males and females, has considered to be hypothalamic, but more recent studies, particularly from Israel, suggest that there's actually an intrinsic gonadal defect, testicular in men and ovarian in women. And this is some data from, I mentioned, Israeli group with 37 men with Prader-Willi syndrome from the age of 4 months to 32. And they found that this hormone called inhibin B, which is a marker of testicular function, was quite low, so, raising the possibility of a testicular problem. But perhaps more importantly, they found that the follicular, and I'll show you a diagram, so for the people, non-endocrine people, it might be a bit clearer. But the control hormone, actually I might show the diagram first. So just as a little bit of background, the way most of our hormones work is that there are factors secreted in the hypothalamus releasing hormones that act on the pituitary, and then there are pituitary hormones that then stimulate the endocrine gland. So in the case of males and testosterone, there are these gonadotropic releasing hormones from the hypothalamus that stimulate the pituitary, to produce luteinizing hormone, and which is the hormone that in turn stimulates the testes to produce testosterone. And then there is also from the pituitary comes follicular stimulating hormone that stimulates the testes to produce sperm. Now, if you have a hypothalamic or a pituitary problem, you would expect to see low levels of the pituitary hormone, LH and FSH, and low levels of testosterone. And if you've got an in turn low testosterone, if you have a testicular problem, you will see low testosterone and normal or high or inappropriate or high, typically high levels of LH and FSH. If you've got a mixed problem, which probably most people with Prader-Willi have, you will have low testosterone plus measurable LH and FSH, but it should really be higher if you had a normal hypothalamic pituitary axis. So what we see is that boys with Prader-Willi syndrome have low testosterone, often a high FSH and an inappropriately normal LH. We won't worry about this anti-Müllerian hormone, that's getting a bit too technical and not that important. In their study of 37 patients, 2 adults, only 2 of them had severe hypogonadotrophic hypogonadism, which means a pituitary problem where there was no, or hypothalamic problem, no LH, no FSH. So most of them had a mixed picture. The other thing that's important, and this is again in boys and girls, is that the ovarian, not only do the testes produce, or the ovaries produce testosterone, but the adrenal glands do as well, and this is not abnormal in PWS. So they do produce the adrenal androgens, androstenedione and dihydroepiandrosterone. So you do see the, and that's largely responsible for the hair growth that occurs at puberty. So, as I've said, that it's a primary testicular dysfunction is seems to be a major component of the hypogonadism in men with Prader-Willi syndrome. In women, it's a similar story, really. So most females have low estradiol levels or estrogen levels, and their low estrogen levels, very low inhibin B, which again is a sign that their ovaries aren't functioning normally, and their FSH is also not low. So if it was low, you would think pituitary problem, but it's actually normal, or high, again suggesting a primary ovarian disorder. Central hypogonadism can occur as well, so you can get this mixed picture just as in the boys. I think I will leave the third point because I think it's getting a bit, I don't know. So you can get, actually it's probably, anti-Müllerian hormone is a hormone that that women, I have to remember, that in early development is responsible for determining whether you're going to develop a male or female genital tract, and is, I might get this wrong, is low in women. So you end up, if you have a low level, you end up becoming a woman. If you have levels present, you end up becoming a man. Might have got that the wrong way around. Have I got that the right way around? It also is a sign of ovarian function, and is used sometimes to determine, how many eggs a woman has. Are they still fertile? So you can actually have normal levels or low normal levels in girls with Prader-Willi syndrome that you see in early follicular development, but as the follicle, normally each menstrual cycle, one follicle develops and becomes a dominant follicle, and normally then this AMH level goes very high. That fails to happen in PWS. So you seem to get early follicular development, but not the full maturation of a follicle, which will ultimately become could potentially, if it's fertilised, become a child. So there are certain specific abnormalities that you can see in Prader-Willi syndrome in both men and women that are quite distinct from other disorders. Now, this is to show you very similarly in the female. It's a similar story where there are these gonadotrophin-releasing hormones from the hypothalamus that affect the pituitary gland, that then result in increase in these LH and FSH levels, which then affect the ovaries to either produce eggs or estrogen, LH, estrogen, FSH, the eggs. We get low normal levels in the early phase of, similar to early phase of the menstrual cycle, but we don't get the normal levels that you see at the end of each menstrual cycle.
So it was just showing in the picture about the low inhibin level, and of course you mentioned about low AMH.
Yes.
So what exactly what's the function of that being like low level of, it's actually impacting the overall?
Exactly what the function is. Look, there might, it's not entirely clear, and I'm certainly not an expert in this field, but it is inhibin normally is produced by the what it works. It affects FSH, so inhibin increases FSH, and it kind of has an effect on fertility, and it's made by the end organ. So if inhibin's low, it can either mean the ovaries are malfunctioning or there's no FSH or LH. Yep. So, so what is the presentation? So we've talked a little bit about the hormonal abnormalities and the etiology. Perhaps more importantly, certainly for a lot of the audience here, is what will we see in people with Prader-Willi syndrome? So as has already been mentioned today, the presentation is quite variable between individuals. And however, most male infants are born with cryptorchidism, which means that their testicles haven't descended. As I've written here, spontaneous descent may occur, but in most boys, surgery, that's what orchiopexy is, just bringing the testicles out, is usually needed. There is a normal transient rise in testosterone in infancy has been described in boys with PWS and may explain the normal testicular and penile size we see in prepubertal boys. As I mentioned before, axillary and pubertal hair growth does occur because it's due to adrenal androgens, and in fact it may falsely make people think that your child is going into puberty normally, that despite the normal sort of hair growth, the testosterone levels are usually very low, and full puberty in boys is extremely rare. As someone mentioned earlier today, some children conversely undergo early or precocious puberty, probably because, my guess is because of their degree of obesity. We know that people without PWS who are obese children tend to go into puberty earlier. Now, importantly, fertility has not been reported in men with PWS. They tend to have small testes with abnormal testicular biopsies, again pointing to this primary gonadal abnormality, abnormality with the gonads themselves. Penile length tends to be near or is often near or a little below normal, and the pubic hair stage is variable. Now that little picture is supposed to be showing you where the testes might lie, and they're brought down into the testicles, because if you leave them there, there is a chance of testicular, very low chance of testicular cancer developing. So we always try to bring the testicles down. Now, let me show them. Clinical presentation in girls. In infants at birth, you can already see abnormalities with hypoplasia of the labia minora and the clitoris. Thelarchy, which is when breast buds start to develop, is often delayed, but does occur, and it probably is due to the conversion of the androgens made by the adrenal glands to estrogen rather than estrogen production from the ovaries. As with males, full pubertal development is rare, but unlike the males, spontaneous menarche, that's the beginning, that's the word for the first period. So periods may actually occur in girls with PWS, although most will develop oligomenorrhea, which is periods occurring rarely, and or secondary amenorrhea, which is where you've had a period or more, one or more, and then your periods eventually stop, and it's at a young age. They'll mostly have small ovaries and low numbers of follicles, so where girls are born with many, many follicles, and as they get older, the follicles drop, and when your follicles are very low, that's when you go into menopause. Girls with PWS at the onset have much lower follicular counts. Fertility is very rare, but unlike boys, a few pregnancies have been documented, and it's suggested that inhibin B may be a marker of gonadal function and potential fertility. So this is a hormone that I don't even know if it can be measured in Australia, or if it's measured. I think it can be measured, but I don't know if it's routine. But this, again, I'm pretty sure it was the Israeli group, a paper I read, suggests that young girls, that inhibin B is measured in girls who have had periods, because that might suggest they can be fertile, and in that case contraception might be an issue, which is something I had never really considered in someone with PWS, because I thought that it would never be, the chances of a girl being fertile I thought was incredibly low. So this slide really relates to the next bit of data I'm going to show you. For those who aren't aware, there's this system called the Tanner stage for boys and girls, and this is a picture for girls showing the different stages of development. So 1 is pre-puberty, and then 2 is just the beginning, and this goes through until normal. So you see, in line with breast development, you see pubertal hair developing. And what I want to show you is in this study the variation in the Tanner stage. So this comes from this same group in Israel who looked at their, and you don't know, probably doesn't, projects reasonably well, looked at the girls in their clinic with Prader-Willi syndrome and divided them depending on whether they had mainly primary hypogonadism, which is the ovarian abnormality, that's this group, whether they had a mixture, whether they had, both pituitary and ovarian dysfunction, whether they had partial of each, and whether they had partial pituitary and low primary ovarian dysfunction. So a mixture of the various abnormalities, and they looked at whether their genetics predicted what they might have. I mean, the numbers are too small to really make that much of it, but I think the main message is that in those girls that they were actually able to examine, quite a variable amount of pubertal development, as low as 2, so it's Tanner stage through 2, through all the way to Tanner stage 5. The other thing that's important is bone density, which again was quite variable. So in some girls normal, but in others already in the osteoporotic range. And these girls, their age was their age, median age, in their 19, depending on the group, between 19 and 26. So why do we worry about hypogonadism? Because it contributes to the reduced muscle mass and strength in both sexes. It is associated with low bone density, an important driver of the but there were elegantly, one of the speakers, I know it was Tricia or somebody earlier today, showed all the other factors contributing to the low bone density. Adverse cardiovascular effects, and importantly, adverse effects. Now, this certainly applies to people with hypogonadism who don't have Prader-Willi, but equally, maybe not quite equally, but similarly, it does have adverse effects on body image, self-esteem, and certainly quality of life. So, I don't know if I'm running out of time. So the management of Prader-Willi syndrome in the hypogonadism in boys. This slide, I think we can, it's clearly important when you're meeting somebody to determine their stage of puberty, to work out at what level of puberty they are, to determine how slowly you're going to build up the hormonal the hormonal doses, and the way that you determine it is by, again, looking at this Tanner stage, and here you've got it for boys, and you can see that with increasing puberty you get the increasing growth of the penis and the testicles, and the increased pubic hair, and you can measure all these in with various instruments, which I don't think I need to go into in today's talk. So let's go on to the treatment of boys. So cryptorchidism should be treated, and it's recommended it be treated early because of the increased risk of malignancy in untreated cryptorchidism. HCG, human chorionic hormone injections can facilitate testicular descent. This is a hormone that we use sometimes for fertility treatment as well, but most boys will need surgery. And another reason that surgery shouldn't be delayed, because those injections usually don't work, another reason that surgery shouldn't be delayed is because you will then get the scrotum won't grow. You have hyperplasia of the scrotum, and so the earlier you bring them down, the more likely everything's going to grow in the normal way. Once the boys are a little bit older, you then need to consider when you're going to actually start testosterone replacement. Now, there is, I think, the most important, one of the important points about starting sex hormone replacement is that there's very little literature, very little trials looking at people without Prader-Willi, let alone people with Prader-Willi syndrome. There's really nothing much in the way of guidelines, and what I've written on these slides is what's recommended for boys, just boys without Prader-Willi syndrome. When we're using sex hormone replacement, we need to think, and this is whether or not a child has Prader-Willi syndrome, but we need to consider the sex hormone and growth of the child, because once you're treating with sex hormone replacement, that can arrest growth. So you need to be sure that growth hormone treatment's been instituted so that you're not delaying growth. And the other important thing in treatment is to start gently and slowly, because of possible just getting used to the hormone levels, getting used to the development of the psychological effects of the androgen treatment and the effects on the changing, just like any adolescent, the change in the phenotype. So we recommend starting slowly and then gradually building up. I'm not going to have time, unfortunately, to talk about all the treatments, but I'm happy to talk to anyone later. So we usually, in our practice at our clinic, is to, and I'm seeing boys a little bit later, but I think even the paediatricians, the practice is to use the oral treatment, Andriol, and which is a very weak androgen, and start quite slowly with just one tablet, gradually building up to one tablet 3 times a day. And then once boys are established on treatment, then we will move on to adult hormone replacement, which is usually in Australia an intramuscular injection that lasts for about 3 months, or a gel that can be applied every day, and they have pros and cons. And my approach is to, as with most situations, is to discuss it with the patient and give them the option, and they can go from one to the other. In women, normally in women, it's recommended that, let's go on, sorry, where are we up to? In women, normally it's recommended in women who don't, in girls who don't have Prader-Willi syndrome, the normal approach is to start with estrogen and use estrogen treatment at very low doses for around 2 years, and then introduce a progestogen. Now, what we do in Prader-Willi, again, no guidelines, and the worry is that if you certainly would warn them about bleeding, and if you're starting somebody young, a younger woman, then I would be using building the dose up quite slowly. But in an older person, in their 20s, I might see someone at that age, you might not start quite so gently. And of course, if someone's already had periods, the approach is going to be somewhat different. In actually treating these women, the important issue is about the bleeding, and some girls, interestingly, really want to have the bleeding. They want to be like their peers, and there are others who are very concerned about it and very anxious about the whole issue of hormone replacement treatment. So it involves a lot of some discussion. Why are we treating? And some of this applies particularly to girls, obviously, both for boys and girls, to prevent osteoporosis. In girls who are having irregular periods, you might be treating just to get their periods a bit more regular, so to prevent what we call dysfunctional uterine bleeding, to improve body image and self-image without compromising height. Of course, pregnancy is not usually recommended in people with Prader-Willi syndrome, and not usually possible anyway, because of their other problems. And there is the risk in a woman having a child with Prader-Willi of having Angelman syndrome, which is the deletion that's carried on by the women. So hence the importance of identifying potential fertility in a girl with Prader-Willi syndrome. It's clearly important in adolescent girls to warn them of the possibility of vaginal discharge and bleeding, of menstruation, and they will need guidance and education to cope with emotional and hygienic aspects of their care. Now, I think that this is just about the various treatments, which again we can talk about the pros and cons. Perhaps one important thing, and having all these experts here, it's good to, I wouldn't mind if someone had made a comment, is that we tend to always use oral estrogens to replace estrogen treatment in Prader-Willi girls or women. And there is, theoretically, we're probably better off using topical estrogens, because oral estrogens increases growth hormone binding and thereby lowers IGF-1 levels. And it's certainly something I haven't been as careful with as I should, and I'd just be interested in it if any experts here had an opinion about whether we should really be using topical estrogen in replacing estrogen in women with Prader-Willi. So I'm ending my talk with a question. I love asking questions, as everyone knows. So thank you.